Imagine for a second that you are watching a massive orchestra.
Okay.
You've got hundreds of musicians, strings, percussion, brass, all playing these incredibly complex rhythms with, absolutely perfect timing. But here's the catch. The conductor is invisible.
That is a very evocative image.
Right. And for the most part, the audience, that's us living our lives, doesn't even know the music is playing.
Hmm.
We go about our day eating, working, sleeping, completely oblivious to the symphony happening inside us until someone drops a cymbal or the rhythm section falls apart completely.
And suddenly the silence becomes deafening, or the noise becomes unbearable. I assume we aren't analyzing Beethoven today.
Not quite. We are talking about the silent conductor of the human body. The gut. It functions with this incredible autonomy, a complexity that actually rivals the brain itself, yet we usually ignore it until it stops working or starts hurting.
Which brings us to the Bible of surgery. Today we are opening the heavy leather-bound covers of Baily and Love's Short Practice of Surgery.
Specifically, we're looking at the 28th edition.
The 28th.
And we are doing a deep dive into Chapter 73, Functional Disorders of the Intestine. Now, I want to be clear right off the bat, because functional disorders can sound a bit dry.
It can, yeah.
Our mission today is to interpret this, not just read it to you. We aren't here to regurgitate the textbook. Think of this as your ready reckoner, your revision map.
Exactly. We're the map. The book is the territory. We want you to go back and read the fine print, look at those diagrams.
Of course.
But we're here to give you the mental framework so that when you do read it, it all clicks into place. This is about understanding the logic of the gut, not just, memorizing lists.
So let's define our scope. The chapter title is Functional Disorders. How do we distinguish that from, the rest of the surgical textbook? Because usually surgery is about cutting things out.
Tumors, inflamed appendixes, that sort of thing.
Exactly.
It's the difference between hardware and software.
Okay, I like that analogy.
Most of surgery deals with hardware problems.
Yeah.
A mechanical obstruction, a tumor blocking the pipe, a hole where there shouldn't be one.
Tangible problems. You can see it. You can touch it.
Right. You can see it on a CT scan. You can hold it in your hand. Functional disorders are software problems. The pipe is open. The anatomy looks fine on the scan. The blood flow is good.
But it's not working.
But the neurogenic, muscular, or chemical signaling is glitching. The machine is intact, but the code is corrupted.
That is the perfect way to view it. And the spectrum we are covering today is huge. We're going to traverse the whole landscape. We'll go from the daily grind of constipation and irritable bowel syndrome things you'll see in clinic every single day.
Oh, constantly.
To acute emergencies like ileus and Ogilvie syndrome, and finally to the rare chronic failures like pseudo-obstruction.
And remember, for the surgeon, these are the trickiest waters to navigate.
Why is that?
Because with a hardware problem, you cut it out and you fix it. With the software problem, if you try to fix it with a knife, you often make it much, much worse.
Okay, so let's get into the wiring before we talk about the crashes. Section 1, the engine room, anatomy and physiology. The text calls the enteric nervous system, or ENS, the little brain.
It does.
Is that just a cute nickname, or does it actually earn it?
Oh, it earns it. Think about this. The ENS has 5 times the number of neurons as the spinal cord.
5 times. That is wild.
It's an incredibly dense network. It's not just a few wires. It's a supercomputer. And it's organized into these 2 main layers, or plexuses.
Okay.
You have the myenteric plexus, which sits between the muscle layers. That's the muscle boss and handles motor function.
The movement.
And then you have the submucosal plexus, which handles sensing and secretion.
But the real magic, according to the text, isn't just the nerves. It's that the gut has its own pacemaker.
It does, very similar to the heart. In the heart, you have the SA nodes setting the beat, right?
Right.
In the gut, you have the interstitial cells of Cajal, or ICCs. These are these sort of fibroblast-like cells that sit in the muscle layers, and they generate a rhythmic electrical slow wave.
So the gut has a heartbeat.
Essentially, yes. Now, the brain, the central nervous system, can influence this.
Sure. Stress, seeing food.
Stress, the sight of a burger, fear, that all send signals down the vagus nerve or sympathetic chains. But, and this is the key to autonomy, if you cut those nerves, the gut would keep beating. It runs the show alone.
That's the silent conductor we talked about.
That's it.
Now, the movement isn't just one big squeeze, right? It must vary depending on where we are in the tract.
Oh, it's highly choreographed. In the small intestine, you have something called the MMC, the migrating motor complex.
The MMC.
Think of it as the housekeeper. During fasting, when you haven't eaten for a while, it sweeps through the gut to keep it clean. pushing residual debris and bacteria down into the colon.
It's the street sweeper coming through at 3 a.m.
Exactly. If that breaks, you get bacterial overgrowth. But the colon is different. The colon is much more chaotic.
How so?
Well, think about the colon's job. It has to absorb water. If things move through too fast, like a water slide, you'd be dehydrated constantly.
Okay, that makes sense.
So the colon actually uses retrograde movements, pushing things backward to keep content in place longer for absorption. It churns. Then occasionally, a few times a day, you get these massive mass movements to clear the decks and move stool to the rectum.
Okay, so we have this complex electrical system with pacemakers and housekeepers. How do we test it when it goes wrong? The text mentions a diagnostic toolbox, and it seems like we've moved past just making people drink chalky fluids.
We have, though the classics still have a place. The old school way was barium studies. You drink the contrast, we watch it move via X-ray. It's great for seeing anatomy.
Like, is there a stricture? Is there a twist?
Exactly. But it's terrible for function.
Why is that?
Because barium is heavy. It's dense, and it doesn't really mimic food. Just because a heavy liquid falls through your gut doesn't mean a turkey sandwich will move the same way.
That makes sense. So what's the standard now for checking the software?
The radio-opaque marker study. It's delightfully low-tech, but highly effective. You swallow a gelatin capsule containing little plastic shapes, rings, circles, lines. We wait a few days, usually day 5, and take a plain abdominal X-ray.
And we just count them.
You just count them, exactly. If the markers are gone, your transit is normal. If they're all scattered through the colon, you have slow transit.
Yeah.
A lazy colon.
Okay.
If they're all bunched up in the rectum, you have an outlet obstruction. It tells us speed and pattern, not anatomy.
Simple and effective. But then there's the high-tech version. The text calls it the astronaut of the GI tract.
The wireless motility capsule, or smart pill. This is fascinating.
It sounds it.
It's a pill you swallow that is actually a little computer. It measures pH, temperature, and pressure as it travels. And it radios that data back to a receiver you wear on your belt.
How does measuring pH help us track movement?
It's brilliant. The stomach is very acidic, right? Low pH.
Right.
The small bowel is alkaline high pH. So the moment the pH jumps up, the computer knows I have left the stomach. When the temperature drops slightly, it knows I have left the body. It gives you precise transit times for every segment of the gut. It's the gold standard for a full system check, but naturally, it's expensive.
It's like sending a probe to Mars, but internal. And lastly, before we move to pathology, what about breath testing?
Hydrogen breath testing. The idea is that human cells don't produce hydrogen, bacteria do. So if you drink sugar water and breathe out hydrogen early, it means bacteria are eating that sugar in the small bowel where they shouldn't be.
So it's checking for overgrowth.
Ideally, yeah. It checks for bacterial overgrowth or malabsorption. But Baily and Love warns us here. It has limited reproducibility. It's useful, but it's not a slam dunk diagnosis on its own.
Okay, so we know how the machine works, and we know how to troubleshoot the code. Now let's talk about when the system crashes. We're moving into section 2. Acute adynamic states.
This is where the surgeon starts to sweat a little. We are talking about patients who look like they are obstructed.
Distended abdomen, vomiting, pain, not passing gas.
All of it. But there is no physical blockage.
First up is ileus, specifically in the small intestine. And I noticed the text makes a very specific correction to the language we use. We used to call this paralytic ileus.
Yes. You will often hear that term on the wards. Baily and Love wants you to strike paralytic from your vocabulary.
Why?
The gut isn't paralyzed. It isn't dead. It is dysregulated.
So it's confused, not broken.
Exactly. And understanding the pathophysiology, the two-phase response, is the absolute nugget of gold here. If you understand this, you understand why we treat it the way we do.
Okay, let's unpack the 2 phases. What happens first when the gut shuts down?
Phase 1 is the neural phase. This is immediate. Say you have abdominal surgery or a car accident, the spinal reflexes kick in, and catecholamines, adrenaline flood the system.
Fight or flight.
It's a fight or flight response. The body says, stop digestion, we are under attack. Direct blood flow to the muscles and heart.
Okay, that makes sense. Short-term shutdown to prioritize survival. But ileus lasts for days. Adrenaline wears off pretty fast. So why does the gut stay asleep?
That is because of phase 2, the inflammatory phase. This is the real troublemaker.
Okay.
When we perform surgery, simply manipulating the bowel, physically handling it, activates mast cells in the gut wall.
Mast cells, aren't those the allergy cells?
Usually, yes. But here, they trigger a cascade of inflammation that recruits white blood cells into the muscle layers of the intestine. This inflammation produces nitric oxide and prostaglandins that actively inhibit the muscle contraction.
So it's an active process.
It is an active, sustained inhibition. It keeps the gut shut down long after the initial stress is gone.
That is a crucial distinction. It's not just asleep. It is actively inflamed. And this explains why you can't just give a drug to restart it immediately, right?
Precisely. This is a common mistake junior doctors want to make. They see a bowel not moving, and they want to give a prokinetic drug to force it to move.
To give it a jump start.
But the text says you can't just whip a tired horse. You are fighting active inflammation. Forcing the gut to contract against inflammation is ineffective and potentially harmful.
So if drugs don't work and we can't operate, what do we do?
The management is patience and support. It feels passive, but it's active physiologic support. We use nasogastric drainage, a tube in the nose, to decompress the stomach so they don't vomit and aspirate.
Right.
And we fix electrolytes, especially potassium.
Why is potassium so important here?
Hypokalemia low potassium is a killer for motility. The smooth muscle of the gut relies on potassium to repolarize and contract. If your potassium is low, the gut physically cannot beat. So fill the tank with potassium. And then we wait for the inflammatory storm to pass.
And preventing it in the first place.
Minimally invasive surgery helps. Less handling of the bowel means less mast cell activation. And avoiding opioids. Opioids are kryptonite to the gut. They bind to mu receptors in the ENS and shut everything down.
Right. Now let's move down the track to the large bowel. This is topic B, acute colonic pseudoobstruction, or ACPO, also known by the classic name Ogilvy's syndrome.
This is a different beast entirely. While ileus is usually the small bowel shutting down, this is massive dilatation of the colon without a blockage. It can look terrifying on an X-ray.
The text gives us a great mnemonic for the causes of large bowel obstruction, the 3 T's.
Yes. If you see a big colon, you have to think. Tumor, torsion, like a volvulus, and tired out. That's Ogilvy's.
Tired out. I like that. Who gets this? Is it random?
Rarely random. There are 2 main groups, and this is crucial for you to visualize so you can spot it on the ward.
Okay.
Group 1 is the frail, elderly patient. Maybe they have Parkinson's and they get a UTI or pneumonia. That small metabolic insult is enough to tip their fragile autonomic system over the edge.
And group 2?
Group 2 is the healthy person who suffers a massive trauma, a C-section, hip surgery, a major spinal injury.
So either a small push on a weak system or a massive shove on a strong system.
Correct. In both cases, the sympathetic drive, the stop signal, overwhelms the parasympathetic drive, the go signal. The colon just relaxes and fills with gas. And the danger here is perforation.
Because it's a balloon that just keeps inflating.
Exactly. And the cecum, the start of the colon, is the thinnest part of the bowel wall. According to Laplace's law, the tension is highest where the radius is largest. So the cecum is the ticking time bomb.
What's the magic number? When do we panic?
12 centimeters. If the caecal diameter on X-ray or CT is greater than 12 centimeters, you are in the danger zone. The risk of that wall splitting open skyrockets. You need to act.
So what's the ladder of management? We start with fluids and fixing electrolytes again.
Step 1 is always conservative, just like ileus. Fluids, fix electrolytes, magnesium and potassium, treat the underlying infection, stop the opioids.
But the move-in?
Ideally, get the patient moving or rolling from side to side to help gas move. But if that doesn't work after 24, 48 hours, or if the cecum is getting huge, we move to step 2, neostigmine.
Neostigmine, this is the chemical restart.
It is. It's an acetylcholinesterase inhibitor. Basically, it stops the breakdown of acetylcholine, which is the neurotransmitter that tells the gut to contract. It floods the system with go signals.
And the text has a huge warning box here. It's not without risk.
Huge risk, because acetylcholine also affects the heart and lungs. It causes bradycardia. It slows the heart rate down, sometimes dangerously.
Oh, wow.
And it causes bronchospasm, constricting the airways.
So you don't just give this on the ward while checking your emails?
Absolutely not. You need cardiac monitoring. You need a doctor present, and you need a syringe of atropine ready in your pocket to reverse the effect immediately if the patient's heart stops or drops too low.
It's like jump-starting a car with a lightning bolt.
It is. It works. It's extremely effective, but it's risky.
If the lightning bolt fails.
Step 3 is endoscopic decompression, putting a scope up to suck the air out. It's tricky because the colon is full of stool and the wall is thin, so you can poke a hole in it.
And step 4?
Step 4, the last resort, is surgery. Mortality for surgery here is high, so we avoid it if at all possible.
Okay, let's pause. This is our check-in point 1. I want to throw a fictional scenario at you, and let's see if our listeners can follow along and apply what we just discussed.
Let's do it.
We'll call her Mrs. G. She's 78 years old, and she is 3 days post-hip replacement surgery. The nurse calls you because her abdomen is huge. It's drum-like tympanic. She hasn't passed gas since the surgery. She's uncomfortable, but not in agony.
Classic presentation.
Okay, so question for you, the listener. Is this ileus or Ogilvy's? And how do we treat her?
Let's pause and think.
Yeah.
What are the clues? Post-op hip is a classic trigger for both. But where is the distension?
You order an X-ray. It shows a massive colon loop outlining the abdomen. And crucially, there is air in the rectum.
That is the key. The air in the rectum tells us there is no mechanical blockage. The pipe is open.
Right.
If it were a tumor, no air would get past. The massive colon points us away from small bowel ileus and squarely toward Ogilvy's, or ACPO.
Exactly. And you measure the cecum on the X-ray. It is 10 centimeter.
10 centimeters. Remember, our danger zone is 12 centimeters, so we have a little breathing room. We don't rush to surgery. We don't even rush to neostigmin yet.
So what's the plan?
We start at step 1. We treat the UTI she likely has from the catheter. We stop the codeine she's taking for the hip pain. We correct her potassium. We manage her conservatively and watch her like a hawk.
And if you missed the two-phase mechanism of ileus we talked about earlier, or why we don't just give drugs immediately, rewind 5 minutes.
Please do.
Because understanding why Mrs. G's gut shut down is key to knowing why we can't just force it open immediately.
Exactly. It's the inflammatory response to the stress of the hip surgery combined with the opioids.
Moving on, we've done the acute crashes, the storms. Now let's talk about the chronic failures, the climate change. Section 3. Chronic impairment with dilatation. The text calls these the zebras.
Rare, complex, and difficult. The main one here is intestinal pseudoobstruction, or IPO.
The text uses a grim analogy for this. Motor neuron disease of the gut. That sounds incredibly heavy.
It's an apt comparison, unfortunately. This isn't just a temporary glitch like Ogilvy's. This is a permanent failure of the muscles, myopathy, or the nerves, neuropathy.
And what causes it?
It can be primary, something you're born with or developed spontaneously, or secondary to systemic diseases like scleroderma, diabetes, or even Chagas disease if you're in South America.
And the prognosis?
It's poor. The gut simply cannot propel food. It just sits there. These patients often end up on total parenteral nutrition, TPN, fed through a vein, because their gut has fundamentally failed as an organ.
And surgery. If the gut doesn't work, do we take it out?
Avoid. That is the rule. Operating on these patients creates adhesions. You take a gut that already can't move, and you stick it together with scar tissue. You make a bad situation tragic.
It's never operate.
The only time you operate is for a venting gastrostomy or jejunostomy to let gas out, but you avoid resection.
What about the large bowel versions, megacolon and megarectum?
Megacolon is often confused with Hirschsprung's disease. But Hirschsprung's is usually congenital diagnosed in babies, where a segment of bowel has no nerves at all. In adults, true megacolon is rare. But megarectum. This has a fascinating, if sad, backstory.
The stool withholding theory.
Yes. This often starts in childhood. A child fears using the bathroom. Maybe it hurt once, they had a fissure, or they are afraid of school toilets. So they hold it in.
And the rectum is designed to stretch, right? It's a reservoir.
To a point. But if you hold it in for years, the rectum stretches and stretches. It accommodates larger and larger volumes. Eventually, the walls become so stretched that the nerve endings stop firing. They lose sensation.
So the signal to the brain that says, I need to go, disappears.
Exactly. They stop feeling the urge. The rectum becomes this massive, flaccid bag filled with stool. They might only go once a week or once a month.
And by the time they see a surgeon as an adult,
it's a chronic, stretched out organ that has lost its tone. It's like an overstretched rubber band. It won't snap back. Treatment involves trying to keep it empty with aggressive laxatives and enemas, but it's a difficult road. It highlights how important those early childhood habits are.
Okay, let's shift gears to section 4. We've done the rare stuff. Now we are doing the stuff that fills the waiting rooms. Chronic impairment without dilatation. The daily grind.
Constipation and IBS. The bread and butter of gastroenterology and general surgery.
Let's start with constipation. The text makes a point right away. Constipation is a symptom, not a disease.
And patients and doctors speak different languages here. This is a classic communication breakdown.
So.
A patient says constipation and means it hurts when I push, or my stool is hard like rocks, or I feel bloated.
But the doctor hears constipation and thinks
frequency. The doctor thinks, how often do you go? If the patient goes every day but strains for an hour, the doctor might say, you aren't constipated. We have to align those definitions first.
Baily and Love breaks the causes down into 3 buckets. I think this is the most practical part of the chapter for clinicians. If you memorize these 3 buckets, you can diagnose anyone.
I agree. Let's walk through them. Bucket 1 is normal transit constipation.
This sounds like a contradiction.
It does. You do the marker study we talked about, and the markers move through at a normal speed, but the patient feels constipated.
So it's a perception issue.
It's often a sensory issue, a low-fiber diet, or psychological distress. Their gut is moving, but their perception is that it isn't.
Bucket 2.
Slow transit. The lazy colon. You do the marker study, and 5 days later, all the plastic shapes are still scattered through the colon. The muscles just aren't pushing. The neural drive is weak. This is common in young women, interestingly.
And bucket 3. This feels like the one we miss the most, and the one with the biggest consequences if we miss it.
Evacuation disorders. The door won't open. This isn't a plumbing problem upstream, it's an exit problem. The medical term is dysynergic defecation.
Meaning they are pushing against a closed door.
Exactly. Normally, when you sit on the toilet and bear down, your puborectalis muscle and anal sphincter should relax to let stool out. It's a reflex. In these patients, that coordination is broken.
What happens?
When they push, they paradoxically contract the sphincter. They squeeze the door shut while trying to push the contents out.
It's a coordination failure. And this brings us to a critical check-in point regarding surgery. Listen closely to this part.
It does. This is the don't cut moment. Imagine you have a patient with an evacuation disorder, a pelvic floor issue. They complain of constipation. You, the surgeon, decide to remove their colon to fix the constipation. What happens?
Well, you've removed the storage tank, the colon, but the door, the anus, is still locked.
Precisely. You have achieved nothing but misery. The patient will still struggle to pass stool, but now, because you took out the colon that absorbs water, the stool is liquid and high volume. So they have liquid diarrhea that they cannot pass. It is a disaster.
This is why the text emphasizes testing.
You must do physiology testing, anorectal manometry, or proctography before you ever consider cutting for constipation. You have to rule out the door problem.
Because if the door is the problem...
Taking out the colon is malpractice.
So for evacuation disorders, if the treatment isn't a scalpel, what is it?
It's biofeedback, physical therapy for the pelvic floor. It involves using sensors to show the patient on a screen when they're relaxing and when they're squeezing. It's about retraining the brain-muscle connection. It works. Surgery does not.
Clear as day. Now, let's tackle the other giant. Irritable bowel syndrome, or IBS.
This is a huge topic. The Rome 5V criteria are the gold standard here for diagnosis. It's not just, my tummy hurts. It is recurrent abdominal pain associated with a change in stool frequency or form.
And the text talks about a paradigm shift. For years, patients were told it's all in your head or there's nothing wrong with you.
That was dismissive and, frankly, wrong. The new model is the biopsychosocial model. We talk about the brain-gut axis. It's not imaginary, but it is neurological.
So what's happening?
Stress, trauma, early life events, they rewire the connection between the brain and the gut.
The hardware is fine, but the sensitivity settings are turned up to 11.
Exactly. It is visceral hypersensitivity. If I put a balloon in your rectum and inflate it, you might feel pressure at 50 milliliters. An IBS patient might feel screaming pain at 10 milliliters. Their threshold for signal is incredibly low.
So normal gut function feels painful.
Normal gas moving through the bowel feels like a knife stabbing them.
Management.
It's holistic. Diet, the low FODME diet, helps many by reducing gas. Drugs to manage symptoms, antispasmodics for pain, loperamide for diarrhea. And importantly, the text mentions low-dose antidepressants, TCAs, or SSRIs.
Now, patients often resist this because they think you're saying they are depressed.
Right. And you have to explain it carefully. We aren't using them for depression. We are using them because they dampen nerve pain. They turn the volume knob on the gut sensitivity back down from 11 to, say, a 3 or 4.
And the cardinal rule for surgeons regarding IBS?
Surgery has NO role in treating IBS. I repeat, NO role.
And it can make it worse.
In fact, it often does. How many patients do we see who had their appendix out, then their gallbladder, then a hysterectomy, and they still have the pain?
Because the pain wasn't in the organ, it was in the signaling.
Exactly.
Yeah.
Every operation adds adhesions and trauma, which feeds the cycle of pain and dysregulation. The surgeon must be the one to say no.
We're coming to the end of our deep dive. This has been a tour de force of the gut software. Let's drop the anchors, the key takeaways to hold on to.
Anchor 1, hardware versus software. Always ask yourself, is the pipe blocked, mechanical, or is the signal down, functional? Use your CT scan to prove the hardware is okay, but don't stop thinking there. Just because the scan is normal doesn't mean the patient is fine.
Anchor 2, the acute versus chronic divide.
Acute dilatation like Ogilvy's or ileus is a temporary storm. You weather it. You support the patient with fluids and electrolytes. You don't panic.
And chronic.
Chronic dilatation like pseudo-obstruction is a failing climate. It's a long-term management issue, not a quick fix.
And anchor 3.
The surgical stop sign. In functional disorders, the surgeon's knife is often the enemy. For constipation, it's a last resort only for slow transit and never for pelvic floor issues. For IBS, it's forbidden. For Ogilvy's and ileus, it's only for complications like perforation.
The surgeon's greatest skill here is knowing when not to cut.
The text actually says something profound about that. It says surgery often perpetuates the patient's search for an organic cause that doesn't exist. It hinders them from accepting the functional diagnosis. If you operate, you validate the idea that something physical was broken, delaying the real treatment they need, which is often behavioral, dietary, or medical.
That is a powerful thought to end on. It changes the role of the surgeon from fixer to healer, in a way. It's about treating the patient, not just the image on the scan.
It really is.
So, listeners, here is your homework. Read Chapter 73 of the 28th edition, but specifically, look at Figure 73.11, the algorithm for chronic constipation. It's a flowchart. Memorize it. It will save you from making a catastrophic surgical mistake on a patient with a pelvic floor issue.
And remember, be the learner. Curious, critical, and compassionate.
See you in the next deep dive.